This video will discuss the assessment, diagnosis and treatment of cuboid syndrome. Cuboid syndrome is defined as minor disruption or subluxation of the structural congruity of the calcaneocuboid portion of the mid-tarsal joint, which essentially means the subluxation of the cuboid from its natural position. It's probably more common than you think, particularly in certain athletic populations. Newell and Wood in 1981 found that cuboid syndrome represents approximately 4% of all foot injuries, and Jennings and Davies in 2005 found that cuboid syndrome was present in approximately 7% of patients with plantar flexion and inversion ankle sprains. This means that nearly 1 in 10 patients with the most common form of the most common sports injury, ankle sprain, may present with cuboid syndrome. Marshall and Hamilton in 1992 found that cuboid syndrome accounted for approximately 17% of foot and ankle injuries in ballet dancers. Cuboid syndrome is frequently misdiagnosed and therefore it's poorly treated. If you do not know what to look for, it's likely you won't find it and your athletes will suffer. In terms of etiology, there's two main mechanisms. Number one is plantar flexion and inversion injuries. So what happens is during rapid plantar flexion inversion, which is the mechanism of a lateral ankle sprain, there is a strong reflex contraction of the peroneus longus muscle. The peroneus longus originates from the fibula and crosses the lateral surface of the cuboid before it inserts on the medial cuneiform and first metatarsal. During this forceful contraction, the cuboid acts as a fulcrum, and the tendon then applies a force on the cuboid, causing inferomedial displacement, or cuboid subluxation. The second mechanism is an overuse syndrome, where subluxation of the cuboid occurs secondary to repeated microtrauma due to vigorous activities. Now, assessment. Athletes with cuboid syndrome will report a mechanism that's frequently in line with the proposed mechanisms previously, although this syndrome can occur insidiously. They'll report lateral foot pain, which is often directly over the cuboid. However, it can radiate down along the fourth ray. The pain will be aggravated by weight bearing, particularly along the lateral foot and toe walking. Objective examination will show observation. You may see inflammatory signs around the cuboid. A dorsal sulcus may be evident with plantar subluxations. A palpable bump may be present for dorsal subluxations, which seems to occur more rarely. Gait, there'll be pain with gait, particularly during toe off. In terms of their passive range of motion, passive inversion is often painful. And active or resisted plantar flexion and eversion is often painful. In terms of passive accessories, there's frequently a reduction in the amount of joint play of the cuboid. However, joint mobility assessment is often unreliable. Therefore, reproduction of a patient's pain is much more reliable and may also be reproduced by tarsometatarsal glides, mid-tarsal adduction, and mid-tarsal supination. On palpation, you'll often find tenderness on palpation of the cuboid, and there's also often muscle spasm evident in the peroneals. Just a list of a few differential diagnoses is important to be aware of, and these include peroneal tendinopathy, peroneal tendon subluxation, sinus tarsi syndrome, Jones fracture, anterior calcaneal process fracture, tarsal coalition, and Liz-Frank injury, and stress fractures. Unfortunately, in terms of imaging, X-ray, CT, and MRI are not helpful in the diagnosis of cuboid syndrome. Imaging, however, can be useful in negating competing hypotheses during differential diagnosis. On to treatment. Soft tissue releases to peroneal and long extensor muscles in spasm. Heat and electrotherapy aimed at the muscle spasm can be helpful. The keystone of treatment involves cuboid mobilization or cuboid manipulation. You should use ice following the manipulation, and then low-dye taping, possibly with a midfoot support anchor or cuboid pad, will help maintain reduction and facilitate return to play. On subsequent treatments, you might find long-standing conditions will require additional mobilization or manipulations. And in terms of exercise therapy, perineal and gastroc stretches are useful. You can find intrinsic and extrinsic foot strengthening, and neuromuscular proprioceptive control exercises may be required. Return to play outcomes. There's very limited research available on cuboid syndrome, and we often see small case studies. But there's positive results. Marshall and Hamilton in 1992 showed that it's possible to return to play following manipulation and with supportive taping within 24 hours of treatment. A word of warning, before you guys attempt to manipulate the cuboid, you must ensure that you're confident and competent with the performance of the technique. If not, attempt mobilization first or simply refer on to someone who knows what they're doing. Trust me, your athlete will thank you. Now, if you guys want to share your thoughts or if you're after more information such as this, you can check us out on Facebook at facebook.com/thesportspt. Follow us on Twitter at thesportspt. And for more information and a full reference list, please visit us at thesportsphysiotherapist.com.